So today's the inaugural webinar, and we're going to start with the first thing. It's Dr. Awazi had said this at one of the lectures, and this is so true. If you never screen a patient, you will never get to treat them like anything else. This is a disease that has to be screened for, and yes, as dentists, we can't diagnose it, but that's okay because we can at least screen it and then refer for diagnosis. And the reason is because okay. And we'll skip that because we have in excess of 30 million Americans that suffer from this chronic disease that's really an epidemic proportion. So we're going to go over today, our topic is to go over the screening process and how to actually implement this into your office. We know that over 30 million Americans at least, and that was a conservative estimate from the last statistics back in 2014. So now just imagine it's just bigger than that. It's now estimated that 60 million Americans suffer from sleep apnea. So if you just look at the general population, 60 million Americans suffer from sleep apnea, and of those, 80% are undiagnosed. And only 20% are diagnosed. And of the 20% that are diagnosed, 85% of those have been prescribed a CPAP, and only 10% have been prescribed oral appliances as first-round therapy. And that's that's a gross underestimation, because if you just ask physicians themselves don't know much about oral appliance therapy, and what they've heard from their patients is that it doesn't work because patients unsuspectingly go to their dentist, and the dentist, not knowing much about it, just that an oral appliance will take care of it, literally take 2 impressions and a bite, an arbitrary bite, send it to a lab, get the appliance made, and fit it for the patient. So majority of the times, you don't reach treatment efficacy. Patient wears it the first night, wakes up the next morning not feeling as refreshed as they were hoping they would, and automatically assumes that it doesn't work. Or worse is they're left to titrate by themselves. Now, titration is a definition of adjusting the dosage until patient symptoms or condition improves. And if you just transfer that to oral appliances, is to constantly adjust the appliance until the patient's report subjective improvements of symptoms or their condition gets better. Then we'll talk about that in a bit. And surgery only 5% of the time, and that too is a gross over-exaggeration, overestimation of the surgery that's recommended. But what is not underreported, and it's exact, is that 100% of the time, lifestyle choices, change is recommended. So about sleep apnea, let's talk about the complications of sleep deprivation. And we went through this, and it's part of your online training. We have tremendous amounts of impaired daytime alertness and function. We have impaired immune system, impaired memory consolidation. By the way, this lecture is available for download. This lecture is also being recorded, so we can actually have it available for you, or for those who didn't get a chance to attend. It's going to be posted on our website, and you can access it anytime. So we also have physical impairment in physical performance. We have impairment in executive and cognitive functioning. So just think about all the times that you didn't really get a good night's sleep, and just transfer that to all the complications and just magnify them, like mood changes, excessive daytime sleepiness, restless sleep, high blood pressure, morning headaches, depression, severe anxiety, short-term memory loss, intellectual and cognitive deterioration, temperamental behavior, poor job performance, and even impotence has been linked to sleep deprivation, which is not as bad as when you're dealing with complications of untreated sleep apnea, dealing with memory issues, mood changes, weakened immunity, risk of diabetes, accidents because of experiencing drowsiness during the day, trouble with thinking and concentrating, high blood pressure, weight gain, low sex drive, risk of heart disease, poor balance, hypertension. So a whole bunch of really serious multi-organ systemic complications occur as a result of untreated sleep apnea. So, so what do we do as dentists? So the definition of oral appliance therapy is to first and primarily treat obstructive sleep apnea, improve their symptoms and primary snoring. And oral appliance therapy is indicated as first-round therapy for mild and moderate cases of sleep apnea and primary snoring in the absence of sleep apnea, but also for severe sleep apnea patients who are not able to tolerate a CPAP or just plain refuse CPAP. So for those, oral appliance therapy is recommended versus no therapy or surgery. So, and for the definition, this has to be, oral appliances have to be a custom fabricated appliance. Just recently, the position came out that it can be done via scanning. So you can scan to take impressions, so to speak, virtual impressions, but the actual physical device, the oral appliance, has to be made on models that have been printed from the scans. So for those who scan, yes, you can. You can take impressions and bites, the MapFit bite, using any intraoral scanner that you used to. So as dentists, how does it impact us? So as you remember, 20% of the general population. So if you just transfer that into our patient base, 20%, that's 1 out of 5 adult patients in our typical general practice, and 1 out of 8 pediatric patients, which is about 12%, suffer from sleep apnea. Of that, let's assume you have a typical dental practice of 1,000 adult patients as active patients. 20% have sleep apnea. That's 200. Of those, 160 haven't been diagnosed. And of the 40 that have been diagnosed at 1 year, CPAP compliance, we're dealing with about 3. So that's an opportunity for 197 patients that can benefit from oral appliance therapy. And this is just a simple, breakdown of not just the importance of oral appliance therapy from improving a patient's life and health, but also from improving a practice's health. If you just compare Invisalign to DSM, everything weighted equally. It takes about 5 contacts per case acceptance. That means you have to really have a conversation with your patients 5 times about Invisalign before they can move forward with it. With oral appliance therapy, it's literally 1, because once you've screened and gone through the process, and it's got to be an exact process, and we're going to go through exactly that, because every single thing you do builds on the necessity part of it. And patients really, once they start to understand how untreated sleep apnea is impacting their daily life and their health, they really do want to move forward with it. And I've been told about all kinds of barriers in terms of medical insurance, but it goes beyond that. It's all about education. And we'll talk about that at a later webinar about the financial aspect of it. But if you just look at the Invisalign versus a dental sleep medicine comparison, for everything weighted equally, by far dental sleep medicine is much more profitable for your practice, and it takes less time, which is remarkable. So you're not just improving your patient's health, but you're also actually improving your practice health. So as dentists, how can we help? The consequences of sleep disturbance are potentially more severe than tooth loss from underlying periodontitis. That's important to understand. Providing treatment for patients who snore, and this is really very important to understand. Providing treatment for patients who snore without formulating a complete and accurate diagnosis is problematic. And for those who've been to the lecture, who've actually gone through the training course, you would have seen the collapsibility of the airway, that OSA is actually a 3-dimensional concentric collapse versus a snoring, which is only a 2-dimensional collapse. So in addition, any treatment of snoring without including the medical profession widens the gap between the professions. And I'll explain that a little bit later. And the same gap that needs to be narrowed to treat the vast majority of patients that have sleep apnea. This approach based solely, that means for snoring, based solely on the patient's reporting of snoring, can be compared to, let's say, treating gingival hyperplasia without a proper diagnosis, including parietal probings and radiographs. If snoring is resolved, the patient often will not seek further therapy because they themselves don't know. And if we don't screen appropriately, we can't help the patients. So just as treating gingivitis without proper diagnosis would be considered below the standard of care, treating obstructive disorders carries the same diagnostic requirements. Consequently, the obstructive disorder may continue and the patient remains at risk for hypertension, stroke, diabetes, and other associated comorbidities. So what are the top 5 barriers to implementation of sleep medicine in your practices? We have lack of education, which we know we weren't taught this in dental school or in postgraduate. We have to find this after we've finished our residency. The low sensitivity and high specificity in patient screening process, which is very inconsistent incidence and severity correlation. So what does that mean? That means the current methodologies of screening, the Epworth Sleepiness Scale, the stop bang, or even the Berlin score, by themselves are not very specific or even correlated to the severity of the OSA. But we will talk about this one way of doing things called sleep SWOT, and we're going to be publishing a paper because we have treated over 1,500 patients as part of apnea. In the 1 year that we've launched, we've treated 1,500 patients. That means our members have treated over 1,500 patients. We have tremendous amounts of data. We have tremendous amount of data that we can actually mine and report that when you start combining severity scales or scoring of different screening processes, the correlation to severity just is so precise that it's without question. So can't wait to share that paper with you guys. And the third one is fragmented commercially biased resources for clinical administrative systems, and the arbitrary, which is a guess determination of a start mandibular position, and the subjective trial and error titration of oral appliances. And of course, the fifth one, the medical billing part of it. And in a future webinar, we will be addressing each and every single one of these. Sorry, just going to silence that. Like I mentioned, the single screening process, it could be an Epworth Sleepiness Scale, could be stop bang, could be Berlin questionnaire by itself, is very inconsistent and extremely poor predictive values for correlating severity of sleep apnea. And realize something, 60% of patients with sleep apnea actually don't report experiencing daytime sleepiness. So daytime sleepiness is defined as hypersomnolescence. So imagine if 60% of your patients who have sleep apnea don't even report daytime sleepiness. So just by asking that one question, do they experience daytime sleepiness, you're excluding 60% of the patients who otherwise would have been suffering, who have OSA. So why is OSA so important? We talked about the complications of untreated sleep apnea. So we know that sleep apnea, untreated sleep apnea, is associated with some major psychosocial and mental and medical health factors. But the interesting thing is, it gets worse as we get older. So a study showed that 65% of Medicare patients by their definition, was 65 years or older. So 65% of 65 or older have multiple chronic conditions like osteoarthritis, hypertension, coronary artery disease, diabetes, cancer, COPD. Just mine your own patient database, and the next time you see an elderly person, somebody who's, well, 65 is not elderly, but anyone who's over 65, just look at their medical history. They come in with a host of medical conditions, and the prescriptions they take, the same study also reported that 90% of over 65 take one prescription medication. 40% of them take more than 5 medications, and 12 take more than 10 medications. That's tremendous. So look at this other study. This other study shows the prevalence of sleep apnea and comorbidities. So in drug-resistant hypertension, 83% of people who suffer from drug-resistant hypertension have sleep apnea. That's a tremendous statistic. Obesity, 77%. So just as I'm pointing out these comorbidities, just think about your own patient database. Just look at today. Just think about today of the patients that you saw in your practices today. And just look at the medical histories. When you review the medical histories, congestive heart failure, 76% of people have sleep apnea. Type 2 diabetes, 72%. Pacemakers, 59%. Atrial fibrillation, 49%. That's one of the leading causes of stroke, atrial fibrillation. That's why people on atrial fibrillation have been prescribed blood thinners. So the next time you see a patient on blood thinners, ask them why they're on blood thinners, most probably on atrial fibrillation, to prevent the likelihood of a stroke. But remember, 1 out of 2, 49% of people with atrial fibrillation have sleep apnea. All hypertension, 37%. Coronary artery disease, 30%. So these are staggering, statistics. So when you start to look at medical histories, you'll start to understand that people with one or more of these diseases, just all of a sudden, it should be at the forefront of your thought processes. Guess what? They might be suffering. And we'll go over some of the other issues that kind of, if you put the whole puzzle together, these are just pieces of the puzzle. But when you start to look at other factors, other pieces of the puzzle, and you start to put the puzzle together, it all of a sudden starts to make a lot of sense. Things like this. When you start to look at predictors of sleep apnea, we talked about the medical history. Medications too. Just by looking at the medications, you know what the conditions are being managed by those prescriptions. And if you know it's a blood thinner, you know it's atrial fibrillation, you know that it's 50% of the times that person might have sleep apnea. But that incidence of sleep apnea just increases if you look at the neck circumference. Men greater than 17 inches, women greater than 15 if they snore. If they report that there's witnessed apnea, that means someone, a bed partner, or someone has observed them stopping breathing and then waking up, choking, gasping for air. Hypertension, if they have a BMI that's greater than 25. So all of a sudden you start to put these pieces together and the puzzle starts to become clearer. When you look at BMI, which is the body mass index, you're looking at normal, that's 18 to 25. Overweight is 25 to 30. So just remember, so 72% of just overweight people have sleep apnea. When you're dealing with obese, the incidence just increases. So obese is 30 BMI to 40 BMI. You don't have to know any of this. The BMI calculator is actually part of the workflow. So if you just put in the patients, or if the patients themselves put in their height and weight, it calculates the BMI for you. But just realize something. For an overweight person, the incidence is 72%, but for an obese person, it's 77%. Studies haven't reported the extreme obesity in extremely obese patients, but if you just look at that, it's definitely in excess of 77%. Now you look at a patient's facial profile. So you've got the class 2 with the mandible is really retruded. So if the mandible is retruded, where do you think the tongue position is? Now, when you look at their mouth and you just think about a room could be normal size, but if you have oversized furniture, how hard is it for you to navigate through? Or if the room is just small, but you have normal sized furniture, again, navigating that room becomes hard, doesn't it? So if you've got a retruded mandible, as in a skull class 2, then all of a sudden the positioning of the tongue is also further back. Now compound that with enlarged tonsils or edematous elongated uvula, and all of a sudden that area becomes even more compromised. Now, if you look at your tongue position, is it's resting above the occlusal plane. If you just ask them to open their mouth and you see their tongue is literally filling up their entire mouth, or they've got these lateral ridges on the sides because the tongue just wants to fit into the mandible and it's just not able to. So it's pressing against the lingual surfaces, and that chronic condition is now causing these indentations on the lateral borders, that should be a sign that the tongue wants to fill in a particular spot. It just doesn't have enough room. So what happens to that tongue when the mouth is closed? There's only one place to go, back into the throat. So imagine if somebody's lying back and the tongue's already there. Guess what happens to the airway? It gets blocked even further. Mallampati classifications, simple thing, as in having a patient stick their tongue out, open wide and stick their tongue out, and can you see the airway? And if you can't see the airway, that means that they're probably going to be they're going to be a real hard time intubating that person. And of course, like anything else, if you can't see the airway, that tongue is going to be falling back, because Mallampati classification 4 is a really low draping palate, soft palate, and the tongue will obstruct it much more easily than, let's say, class 1. And of course, we look at the palates all the time and realize something. The diagram A reflects a normal palate development where the maxillary teeth, maxillary molars, are in the correct alignment with the buccal cusps of the mandibular teeth go into the central groove of the upper molars. But what happens when the maxilla starts to get constricted? Then you have a reverse. You have a crossbite. But also realize something. The palate is the floor to the nasal base. So if the palate's constricted, the nasal base is constricted. That means the nasal passages are constricted, and it's going to make for restricted airflow. So the person with the narrow palate with a crossbite is most likely going to be experiencing difficulty breathing through the nose, and most likely will be compensating by breathing through their mouth. So it's very simple as open their mouth and just look at the back of their throat. So if they've been breathing from their mouths all night long, the back of the throat's dry, it's reddened, the uvula is reddened, the soft palate's reddened, and chances are they probably report that waking up with dry lips because they've been breathing through their mouth. So when you look at the palate, especially with kids, and you see the mid-palatine suture, because the palate's the floor to the nasal base, if you just track the mid-palatine suture through the nose up, it actually is where the nasal septum would be. So if you've got a shift in the midline, in the palate, then you know that the septum is actually deviated. So when the septum is deviated, it actually constricts the part of the nares and the nasal passages, and that kind of obstructs airflow from that part of the nose. So that means the person has to breathe that much harder from their nose. And a lot of times, you just can't breathe hard enough to get airflow without restrictions, so you start to compensate by breathing from the mouth. So all these things, if you start to pay attention and start putting the picture together of the medical history and what you notice in the mouth, from the mouth, and the clinical findings during a regular dental exam, and actually your hygienists are prime candidates to do the screening for you, because they spend so much more time with the patient than you actually do. But this is the other thing. When people complain about bruxism, look at this statistic. Bruxism is, and especially nighttime bruxism, has been actually classified as a parasomnia. It's actually a sleep disorder of parasomnia. It's a movement disorder. But imagine this, with a diagnosis of sleep bruxism, 74% of the patients, 74% of the patients actually report grinding their teeth. 74%, that's 3 out of 4 patients with sleep apnea actually grind their teeth. So that's a pretty significant statistic. And what happens is when you have patients who grind, what's the therapy that you prescribe? A night guard. But realize something, that night guard is fitting on just one arch, and is actually taking up the room that otherwise would have been occupied by the tongue. So if you start to constrict the space that the tongue needs to occupy, and all of a sudden the patient falls asleep, and the tongue can't occupy the normal space, where do you think it's going to go? Back into the throat. So actually, for those patients who have sleep apnea or borderline sleep apnea, giving a nighttime night guard can actually tip them over. If they're on the cusp, on the brink of experiencing apneic episodes, it will actually tip them into the zone of apnea. And for those who actually have apnea, make their collapse worse. So that's why when people grind, it's best to first screen them. And if they test high on the sleep SWOT to actually refer for a sleep study and then rule out sleep apnea before you fabricate an oral appliance. Because unsuspectingly, very innocently, you could be actually making their condition worse. So, as part of the whole thing, we've got this resources section for you, which is completely at no charge for you guys, and you know that. But we've got tremendous amounts of resources. We have marketing letters. We have sleep screening forms. We have frequently asked questions section. We have brochures and posters and certificates, your credentialing certificates in there. So when we look at the letters are actually very, specific, branded to your practice. And it was actually Ray that pointed it out a while back, so we made some corrections for it. But these letters, which are in the generic resources section, are not branded to the patient. They're not patient specific, but they are practice specific. So we've got OSA fact sheets that you can actually download as PDFs and send it out to your patients, making them aware of what sleep apnea is. This could be like an email blast with an attachment of this fact sheet, all for you. And we also have announcement for patients that you're treating sleep apnea with oral appliance therapy instead of a CPAP. But as you can see, they're all actually branded to your practice. You can actually choose, if you have multiple locations, you can actually choose which location you want to send it out from. So every single one of those letters in the resources section is not patient specific, but practice specific, and you can actually do that. We also have brochures and posters for you that you can literally, they're print ready. You can just literally download and print and have them for you in your hygiene exam room. These are the brochures for you that you can download. And of course, we have the sleep SWOT. We have the stop bang questionnaire for the clinical team, and the Epworth Sleepiness Scale for the for the patient. So what I would recommend is you actually download as many of these, print it up, and have it ready for the morning. So for the Epworth Sleepiness Scale, hand it out to all your patients as a basic screening intake form when you do your medical history, when you give them paperwork to fill out, updating their medical history or insurance information. Just hand it out and they can complete it. So we can skip that. So what we do, what I recommend doing, is print up as many of these brochures as possible, have it available for your patients in the waiting room. And these are all print ready, and we're actually making Spanish versions of these, which should be available pretty soon. And as soon as they're uploaded onto the resource section, we'll send an email out to everyone that it's available for you. And again, you can just literally download them and send it to any printer, Staples, Vistaprint, and then distribute it to your patients and have it ready for them. So same thing with posters. So we have sleep apnea posters, and these are high resolution, so you can print it up as big as you'd like. You can even print it up for a billboard if you'd like. And we also have it for snoring, and this is all about awareness. So think about it. The video that you just saw is actually available for you in the main page, in the landing page. But you can actually have this, and we're going to send out the link to this. It's actually on the website, so you can actually have it as a quick link on your desktop. Just like, imagine Invisalign, you've screened a patient and you've identified dental crowding and you want to prescribe Invisalign therapy. You show them that Invisalign video and you hand them the brochure. It's the same exact way. You can actually have a quick link on your desktop and you can just show them this video. The hygienist can actually show this video while they get you. Before you even come in, they should be preheated with this video. the posters in your practice in the hygiene room should be, should be available for the hygienist to kind of point and show, and also brochures to hand out. And then, of course, like anything else, once you have, here we go. I think we did this. There we go. So, like anything else, we have the Epworth Sleepiness Scale, which is literally 8 questions. It's about the likelihood of them falling asleep. 0 would be never likely. 1 is slight chance of dozing off, 2 is moderate chance, and 3 is high chance of dozing off. Just simple questions like sitting and reading, watching television, sitting inactive in a public place, as a passenger in a car, lying down in the afternoon, sitting and talking to someone. I mean, imagine people who are that tired can actually just, fall asleep while talking to someone if they're listening to someone, sitting quietly in a room without alcohol after lunch. In a car, even as a driver, when stopped at a red light or at a stop sign. That's one of the things we see that is in patients with extreme sleep deprivation, or medications or alcohol that puts them in a sedative state. They can literally fall asleep behind the wheel and roll into an intersection from a stop sign, and get into an accident and hurt someone. So that's the Epworth Sleepiness Scale that the patient fills out in the waiting room, and they literally score themselves. On the bottom is a scale that they can actually, once they tally up the score, it tells them their likelihood of severity. But by itself, that doesn't mean anything, because remember, 60% of the population with sleep apnea report absolutely no tiredness during the day. But now let's take a look at this. So you've done your clinical exam, you've looked at the medical history, you've done your clinical exam, and you suspect it. But then your hygienist actually does this before you even come in. It's called stop bang. And this is actually for the clinical team. S starts, it's for snoring. T is for experiencing daytime tiredness. O is for observed apneic episodes. P is for blood pressure. B is for BMI. A is for age, because we know as we get older, the index for sleep apnea, the incidence of sleep apnea actually gets worse. And we know that over 50, the physiology changes and the anatomy changes to the point where we are much more predisposed to sleep apnea. And same thing for women. Postmenopausal women, the incidence of sleep apnea actually catches up to that of men. So N is for neck circumference. We talked about the 17 inches for men or 15 inches for women. And gender, if you're a male, you're much more predisposed to sleep apnea. One more thing to complain about being a man, but guess what? Women, the incidence catches up in the postmenopausal because of hormone regulation and the change in hormones. So now, if you just compare the two, so it's a very simple thing. The number of questions you answered yes to. For a 0 to 2, there's a low risk for OSA. For 3 to 4 yeses, that's an intermediate risk, and 5 to 8, that's a high risk. So now all of a sudden, if you score, let's say a 10, and if you score on 10 on the Epworth Sleepiness Scale, and you score, let's say, a 4 on the stop bang, the two, if you combine the two, they both report moderate risk and intermediate risk. So there's a likelihood of this person suffering from sleep apnea, and we're going to be reporting a study because we did the meta-analysis that the incidence of when the patient's been diagnosed, the AHI that defines mild, moderate, and severe is very highly correlated to when you look at the two and you choose the lesser. So if on the ESS you score, mild, but on the stop bang you score moderate, they will score a mild on the AHI index. So it's pretty incredible. Can't wait to share that with you when the time comes. But like again, so when you've scored these two together, then show the patient the video that's on the website, hand them a brochure if they don't already have it, point to the poster that you have in the hygiene room, and then once you've done that and the patient understands that they need to be screened, then guess what? Simply add them from within your dashboard. just add them as a patient. Once you add them as a patient, it's pretty straightforward. It's simple 7 questions, which you already have. So you don't actually have to ask them for these answers. Just have to have their approval that if it's okay, if you would like to kind of do a deeper dive into this, because your ultimate goal is to help them, with managing a condition that's life-threatening if they have it. But you can't diagnose it, but you can screen for it and refer appropriately for diagnosis. So these answers you already know in your practice because these are patients of your practice. Patients can also actually find you through the through the online search, and if they happen to stumble upon apnea because they're doing searches on alternative to CPAP or a whole bunch of other keywords, they can actually look for you or sleep physicians and find you and request appointments with you. So if you do that, you just literally ask very pointed questions like their name, their first name, middle initial, last name, their email address, which you already have in your database, their phone number. So you literally don't even have to ask them. Just have their permission if it's okay, if you can do a deeper dive into this, because your goal is to help them. And you need more data. And the first step is to really get a better understanding of their sleep history, of their medical history. So just by simply adding this patient as a patient, they actually get an email notification that they've been added, and they have a link to fill out their medical history online. And the same process occurs if they were to find someone, if they were to find you through an online search and request an appointment. As soon as they request an appointment, you actually get an email notification in your dashboard and in email that a patient has requested an appointment. You literally just have to go in to your dashboard, and then the appointment, the actual patient's request is sitting there. You just accept it because they would have written down what the chief complaint is that they're looking to address. And once they do that, you can also view their medical history and their entire pre-examination forms before they even come in. So the first thing you do is, after you've added the patient, is, because these are very predictive, progressive algorithms and very dynamic fields, and that's one of the reasons why we can't really have them in a downloadable paper form for you to fill out, because depending upon the answer you give, a different sets of menus come up. And because it's so dynamic, it's impossible to have it in a static form. So the simple questions like, has your patient ever been diagnosed with or suspected to suffer from sleep apnea? It's a yes or no. If no, do you suspect that your patient suffers from sleep apnea, but they snore? You don't suspect your patient has sleep apnea because they scored virtually 0 on the combined sleep SWOT forms, but they do experience excessive daytime sleepiness, and that's possible. Do they have a sleep study? Just simply answering these questions guides the computer, the analytics, into the appropriate workflow, into the most efficient and analytical workflow. So the patient completes their medical history forms, the pre-examination visit forms that includes their medical history, their medical insurance information, their dental insurance information, their sleep history, a whole bunch of different things. And then once you do that, once they complete that, once they complete this, you actually get an email notification the patient's completed, and that's a trigger for you to actually initiate that face-to-face conversation that's required. So we're treating a medical condition. It's very important that we pay attention. We pay very close attention and abide by the rules of medical treatment. So you can't really initiate any therapy without first documenting that initial face-to-face consultation. That's necessary to be documented for not just the regulatory requirements from archiving medical information and archiving visits, but also for medical insurance purpose. Because in the event of an audit, this is a form that you can actually even easily produce, because everything is archived and time and date stamped. So that face-to-face examination is the sleep screening form, which is absolutely mandatory. And right from here, you can actually, complete the sleep screening form, and then you start the process moving forward. So I'm going to be opening up the chat for questions and answers, and I'll try to answer as many as possible, and we can stay as late as possible. I'll try to answer as many as possible in the order that I get them. But the goal of oral appliance therapy is literally, the goal of oral appliance therapy is improving the quality of life of your patient. Give them a fighting chance, because without therapy, they're literally dying a slow death, and all their medical conditions are actually getting worse. Of course, improving their RDI, which is a respiratory distress index, disturbance index, or the AHI, the apnea-hypopnea index. So we definitely want to improve those. We want to improve their sleepiness during the day. We want to improve their medical conditions, like the blood pressure. And it's interesting, as soon as you start to regulate some of the comorbidities that the patient's experiencing as a result of, that were once a result of untreated sleep apnea, as soon as you start to treat sleep apnea and start to manage it the correct way, a lot of times, a lot of these comorbidities actually start to disappear, or worse, or lessen actually in their severity. So all of a sudden, that person who was really resistant to drugs for blood pressure, all of a sudden becomes that much more, manageable. Fatigue improves, sleep quality improves, and as a result, they're just a happier person. So the quality of life is, the improvement is the primary goal, but also improving their sleep apnea indexes is the ultimate goal for oral appliance therapy, and we should never forget that. So next time, we will actually go through the next phase of the workflow, which is the sleep screening, which will be the sleep screening form, the financial agreements, and the predetermination for medical insurance. So thank you, guys, and hope this was helpful. And like anything else, feel free to email and or call. Most of you know that I'm very easily accessible via email. Dr. Sharar, Dr. Awazi are just as easily accessible via email or phone calls. But let's go through the questions. Okay, the first question is from Brian. What would be some of the patient's needs but has caries or broken teeth and requires advanced restorative? This is a great question. So if a patient has advanced restorative needs, periodontal disease, broken teeth, as part of the sleep screening form, you will identify these conditions, and you would actually have to treat them before you actually do oral appliance therapy. So just think of the possibilities of all the untreated dental conditions that are present with your patients. Once the patient understands that sleep apnea is a life-threatening condition and managing it is paramount, then all of a sudden, and that oral appliance therapy is predicated upon a healthy mouth, then all of a sudden the urgency is obvious. They want to move forward with taking care of everything that they had neglected for so many years, because they didn't realize that that their life-saving therapy would be predicated upon having a healthy mouth. Brian, did I help answer that? Great. Of course. So Virginia asks, if a patient requires retention after completing Invisalign as well as oral appliance therapy, can this device provide adequate retention? So yes, for now, you actually can embed, or you can actually have the laboratory embed a retainer inside the oral appliance, or you can just have the patient wear the retainer, and then you can do the oral appliance over it. But realize something also, the oral appliance, if it's a rigid oral appliance, not with a soft cushion or liner, can actually act as a retainer by itself because it's a bimaxillary appliance. They have to wear it on the upper jaw and the lower jaw, and it's pretty stiff. So that stiffness itself can act as a retainer by itself. But if you feel comfortable, you can actually take an impression of the retainer. So you can actually have the retainer in the patient's mouth, take an impression of that, send that or scan that and send that to the lab with a mat fit bite. And they can actually fabricate the appliance to fit over that retainer. Welcome. Hey, Ed. Hi, Stephen. So while that's being typed, so what I would recommend while the questions are being typed, just have those brochures downloaded, printed, and ready for you to distribute to your patients in the waiting room. Okay, the question from Saeed is, let's go through this. For existing patients who wear CPAP and are unwilling to consider oral appliance therapy, would Invisalign hinder breathing similar to how mouth guards would? Not really. Yes and no. Yes, but not as much as a night guard because Invisaligns are so thin, they're about 1.5 millimeters thick. And if you just look at the collective upper and lower, um, it's about 3 millimeters, which is a lot thinner than any night guard that you have. So yes, it's not ideal, but if retention is that important, then what I would recommend is just do like a lingual arch wire, a lingual retainer, and that bypasses the actual retention. So we have a question from Ed. I have several patients that after wearing Prosomnus micro appliance begin to get loose and they take it out while sleeping. Any suggestions? Yeah, so appliances do get loose over time. They're plastic and plastics deform over time, especially if somebody's been clenching. But that's why it's so important that every time that patient come back to your practice for hygiene visits, that they bring their appliances with them. Just like with Invisalign, they have to bring it's always recommended that they bring their retainers with them so you can actually look and see if the retainers are still in good enough condition to act as retainers. So that's a perfect opportunity if the retainer is cracked or loose or not fitting well to have that conversation with the patient that perhaps it's time to change to a new retainer. Same thing with oral appliances. If you see that the oral appliance is starting to chip, crack, warp, and not fitting well, then it's a perfect opportunity to have that conversation with the patient that a new appliance would be indicated. But some appliances are more susceptible to this kind of deformation because realize something. It's all about, we still live in the physical universe, so laws of physics still dictate. Prosomnus appliances are very thin by nature, and that's one of the biggest appeals about them, that they're very thin, but at the same time, because they're thin, they're also much more susceptible to deformation, and that's the sad part. So if they become loose or they start to not fit as intimately, then perhaps a new appliance is indicated. And the thinner the appliance, the greater the risk of premature, wear-related instances. And did I help? Did I answer that? Okay, so we've got one from Stephen. Has there been any reported incidents of mobility of existing teeth when the appliance is worn over time? Yes. Okay. So this is a great question. The incidence of mobility. So that's one of the things that is part of our informed consent. So before we treat, we have to get informed consent. And for those of you who've experienced the entire workflow, you would have noticed that at the beginning of the MATFIT workup is the informed consent. It's clearly stated that mobility of teeth, changing of bite are a possibility over time. And enough studies have shown that. And that's because the appliances start to wear. And as they start to deform, they take the teeth along with them. So if you're starting to have slight, like anything, like even with the retainer, if the retainer is not stiff enough, how well is it functioning as a retainer? Same thing with appliances. If you start to get wear, or the insides start to wear, where the interproximal indentations are worn, that allows for movement of teeth, that's fine. The mobility of teeth, if there's existing periodontal disease and if there's existing mobility, it will get worse over time, without a doubt. Now, if you have good, healthy periodontal teeth that are non-mobile, then the mobility over time doesn't really, if you really are changing the appliance when it's time to be changed, you don't really experience that. And if you use appliances with, say, these ball clasps as retention mechanisms, these ball clasps act as spacers. So think about when you're trying to do fixed palate expansion on children, you put these rubber band spacers between the molars, that within a few days, teeth shift apart and you can actually slide a molar band around the molars. These ball clasps, when fitted really, really intimately, interproximally, will actually act as orthodontic appliances and cause teeth to actually separate. So I'm not a big fan of ball clasps, and I had this conversation with Somnomed this past weekend when we were together, and they will actually, I'm just going to report this out to you guys now because you will actually hear from Somnomed itself in just a few months. They will actually discontinue the ball clasp appliances because the data that I showed them. So it's pretty incredible the amount of data that we can report collectively as a group. We can actually make some great changes in the profession and the way patients are treated. I hope I was able to answer that, Stephen. Okay, so how do we handle the dentulous patients that can't tolerate a CPAP? This is a great question. This is a great point to then introduce two implants in the mandible and a locator-supported appliance. So as part of the workup, if you haven't already experienced it, it will actually help you work up an edentulous patient that has a vertical dimension that's been, that's actually pretty good. You can actually fabricate appliances on dentures. As long as the dentures are fitting well and are retentive, you can actually use appliances with them. Now, if the denture is not fitting well, then it's a great opportunity to consider a new denture that's better fitting, or in the event that even the best possible denture can't be, stabilized on the gums and the existing arch, the ridge, then perhaps implants would be helpful. And what a great opportunity to have that conversation with your patients about two implants with locators to not just anchor their dentures for better fit, but also help with the appliances. Great. We have another question. How frequently does medical insurance typically cover oral appliance therapy? How long do these appliances typically last? So the first question is, on an average, every 3 years, a medical insurance company actually covers oral appliance therapy. Unlike, let's say, a crown, which is every 5 years, because they realize that oral appliance therapies will chip, crack, deform, lose their fit and form, and that needs to be replaced. And depending upon the appliance, like Prosomnus, in Ed's experience, I don't use Prosomnus because there are a couple of different issues, but I'm not going to go into that. But the thinner the appliance, the more likelihood it's going to deform, the more likelihood it's going to experience premature wear and cyclical fatigue from like chipping and cracking. So it all depends on the appliance. Plus, it requires that you really pay attention every time the patient comes in. Ask them to bring their appliance with them. So you just don't actually make sure that the appliance is still in good working condition, but also take that opportunity to clean that appliance. So when the patient is undergoing hygiene, the appliance is being cleaned out in the ultrasonic. Hope I answered that. Great. Okay, question from Randy. How do you handle what? Let's take a look. I think I may have answered a question that he had. So Edge said, how long do you tell patients appliances may need to be replaced, and how to charge? So we don't make any guarantees on appliances. All about how well they take care of it, like anything else. If they misuse it, if they abuse it, if they throw it around or let their dog chew on it, it's not, ultimately patients have to take responsibility for their well-being and for their appliances. If you have a practice where you actually offer patients insurance for their appliances or for their dental treatment, this is a great opportunity to let them know that they can purchase, an insurance, so to speak, against accidental breakage or loss. But for the most part, let the patients know that there is no set standard as to how long an appliance typically lasts. It all depends on how well they care for it. So, if they abuse it, it won't last as long. If they take good care of it, that means brush it and store it in a nice dry place and not let mold grow all over it. Then yeah, it will last a long time. But if they don't pay attention to the daily care, by the way, the Oral Appliance care instruction form is available for you guys in the as part of the FAQs, and also as part of the workflow. When you deliver an appliance, at the time that you literally close out that form, the proof of delivery of the appliance is generated, and care instructions as well are generated. So the patients actually get in their inbox all those forms, and you can also print it and give it to them. And that's also another way of making sure that you've followed the compliance regulation rules, that you enable the patient to manage and maintain their condition, and whatever DME, which is the durable medical equipment that you're giving, which is the oral appliance, that they be instructed on its care. So that takes care of that as well. Oh, great. Very good. Okay, so another question. Is there going to be another apnea course like this, course like there was in February? So there's none planned as yet. It was because of a lot of our members wanted to experience a live course, but everything in the live course plus more is covered in the online course. But if our members or vendor partners feel that actually pretty good, that a live course is necessary, then absolutely, whatever it takes to get our members up and going and getting them used to the workflow and getting them using the workflow, we're all for it. Any more questions? Okay, we have one coming in. So the question is, you mentioned wearing the appliance over well-fitting dentures. I've always been told that patients have been told patients to take out prosthesis at night. Any precautions about minimizing risk of fungal infection? Yes, absolutely. So if you remember from dental school, you were taught to tell patients to take their dentures at night. But how many of you, just by a ding, how many of you have actually experienced a patient coming back to you and refusing that they not go without sleeping with a denture, and they prefer to sleep with a denture in place? And the reason is because Oh, I miss your emails. Oh, that's sweet. Well, you can always reach out to me anytime you'd like. But in any case, so realize something, vertical plays a big role. So as soon as the patient takes out their denture, the vertical collapses and the airway collapses. That's why patients overwhelmingly prefer to sleep with the dentures in place, because it actually restores their vertical and helps with their airway. So now when it comes to minimizing risk of fungal infection is to maintain oral hygiene. And how do you care for your dentures? So patients don't really know. I mean, like anything else, fungal spores will grow in a humid environment, right? Wet, humid environment. We don't have a wet, humid environment. We don't have a wet environment at night during sleep. It's a dry environment. People don't salivate as much. We still salivate, but we don't salivate as much. It's still warm, but that's where, in the morning when they wake up is to really clean their dentures very well and clean their dentures really, really well before they put it at night. And also not just cleaning the dentures, but also maintaining good oral hygiene. So, when the dentures are out, it's a perfect opportunity for the patients to really, wash their mouth out really well. I recommend actually taking a wet gauze pack and literally wiping their mouth from the inside with a wet gauze, um, because the wet gauze actually acts like a little micro brush. Um, so to minimize the risk of fungal infection, hygiene is key. Appliance hygiene and oral hygiene, even in the dentulous patients, it's the key. And also, fungal infections happen. How many times have you heard patients with dentures, without the dentures, they get angular colitis, cheilitis, because they're overclosed and the commissures of their mouths trap all the saliva overnight, and they get these fungal infections. But imagine if they were to sleep with the appliance, it restores their airway, and it actually prevents that commissure from collapsing. I hope I answered that. Hey, ding. That's funny. Do you have a preferred appliance that patients seem to tolerate better than others, connected versus separate with wings? So my go-to appliance is a very simple appliance. It's a dorsal fin. It's a two-piece appliance, so one fits over the mandible, one fits over the maxilla. And when it's made in the mat fit titration, mat fit bite, so to speak, then literally the patient can separate their mouths and yawn without having to worry about it. Um, and and it comes in a soft liner, so it's relatively inexpensive. And pretty soon we're going to be reporting a great collaboration with SomnoMed, where our clients, our members, will actually benefit from that relationship with SomnoMed in many, many ways. Education is one, discounted appliances is another. I can't wait to release that information in the next few weeks. Okay, so Brittany says, that all makes sense. Thank you. Oh, you're welcome. Okay, we're getting another question. Whenever I hear you speak, I always learn. Thank you. Oh, yes, it's great news with SoundNomad. Yeah, I think you'll enjoy using it again. They're going to be revamping their entire product line pretty soon. I'm going to help them with that too, which is tremendous. So yeah, look forward to that affiliation. Good. How's everyone doing? Do we have any more questions? No? Well, you all know how to get in touch with me, right? Well, anyone online doesn't know how to get in touch with me, please let me know. Just put a message here and I'll make sure that I send you my contact info. Great. Do we have any more questions? Oh, thank you, Randy. Great. Well, I can't wait. And we're going to do this on a regular basis. Today we had a slight glitch, so we're a few minutes delayed. Thank you so much, everyone, for bearing with it. But now that we've got the hang of this new platform, I have to say a big shout out to my tech team who put so much hard work into putting this whole thing together. They're just incredible. We'll actually have this webinar for you guys on our website for you to review at any time. You also have the lecture, and like anything else, always feel free to reach out anytime. Oh, you're welcome. Thank you. I'm just getting a few more messages in, make sure we don't have any more questions. Thank you. Oh, very important thing I forgot to mention. So the next webinar is going to be April 16th, but the one following is going to be sometime in May, I think May 6th or so. But we're going to do something really interesting because, you know, I've been helping a few of our members with some really, really interesting cases that they're working up. And I figured, why not take that opportunity for everyone to learn? So what we're going to do is we're going to extend it to an hour and a half, where we'll actually give half an hour, that's two 15-minute time slots, to two members to present their cases. So basically, it's going to be like a grand rounds that we do at the hospital, where chief residents or residents actually present cases to the attendings. So any one of you who, of course, will, you know, for HIPAA's sake, will block out and wipe out any sensitive information, patient information. Oh, you're welcome, Dale. But we'll actually have grand rounds format. So there'll be this the webinar and questions and answers, but two of our members will actually have the opportunity to present cases that they feel that everyone, all of our members, can actually benefit from learning. So how does everybody feel about that? And for that, I would ask if those who would like to provide those cases actually submit them or reach out to me personally, because we need them submitted 3 weeks before the actual webinar where we'll actually present it, so I can help them put it together and, you know, coach them if they need any coaching, so that they can present, that we can all benefit from, because I think that collectively we all have such unique, you know, unique cases that I think we can all benefit from. You're welcome, Bill. So the question is, Ed invited several colleagues to join this webinar tonight, and how can they learn more and become certified if interested? It's very simple. Just go to apnea.com, and once they go to apnea.com, you know, they can just browse around. It's they literally go to, you know, for professionals, which is in the upper right-hand side, right here. So they can actually go to the main page, and up here would be for professions. And if they click it, they will actually get a set of menus to actually register. And, you know, registration is completely free of charge. There's no charge to register, be listed on the website as a provider. From there, they can actually, you know, go through all the different resources that's available. And then right from there, they can also take the certification course and exam. And once they're certified, they can actually then start enrolling patients into treatment. Or they can just reach out to me, just send me an email, and I'll be happy to guide them through it. You know, they can just send an email to tech@apnea.com, and they can also help. Or, of course, mine is, and that's my email address. And you can always reach out to me, and I'll be happy to help you. If you have no more questions, I look forward to seeing everyone at our next webinar on April 16th. Thank you.